Good morning. Welcome to SR PHARMA GYAN. Today we are going to discuss on the SGLT2 inhibitor. So SGLT2 inhibitor, it is a comparatively new class of oral hypoglycemic agent. Now before we go to the SGLT2 inhibitor, we need to focus on the glucose transporter. Now whenever we are talking about the glucose transport across the membrane, these membrane transporters, different membrane transporters plays the important role for glucose transportation. In human, major two type of glucose transporters exist. These are the GLUT already we have seen into our previous lectures, GLUT or the facilitative glucose transporter, and SGLT, that is the sodium dependent glucose transporter, SGLT. Now whenever we are talking about the SGLT, it is mainly coded by the SLC5A gene, and there are different types of this SGLT are present. Now these are the two, SGLT1 and SGLT2, that is the two major glucose transporter. These are the sodium dependent glucose transporter, sodium dependent glucose transporter. Next is glucose sensor. Now this is mainly expressed into the skeletal muscle. This is mainly expressed into the skeletal muscle and nervous system. This is the SGLT3. That is the skeletal muscle and the nervous system. Next, inositol multivitamin transporter. These are the SGLT4 and SGLT6. Generally, SGLT4 it is found into the pancreas. This is found into the pancreas, while that is the SGLT6. This is the myoinositol transporter, and these are also play important role into the glucose transportation or uptake. And thyroid iodine transporter, that is the SGLT5. Clear? SGLT5. Now this SGLT5 also expressed into the recent some evidences found that they are expressed into the renal cortex, though their function it is unknown and it is considered as a orphan transporter. Now in 1960, if we see about that, 1960 Robert K. Klein, first he discovered the sodium glucose transport as a mechanism of the intestinal glucose absorption. So these are the different SGLT are there in human body. Now coming to the SGLT1 and SGLT2, because these are the two major glucose transporter. SGLT1 it is expressed into the intestinal mucosa enterocytes. SGLT1 it is responsible for the glucose absorption in the small intestine, glucose absorption in small intestine, and some recent evidences suggest that this SGLT1 is expressed into the luminar brush border of the erythrocyte, and this is responsible for the nutrient absorption. And in this SGLT1 also expressed into the enteroendocrine L cell and K cell, which produces the incretin, clear, which produces the incretins GLP1 and GIP, which we have discussed earlier. And this SGLT2, mainly this, whenever we are talking about the SGLT2, this is important, the proximal convoluted tubule. In proximal convoluted tubule, both SGLT1 and SGLT2 are expressed in proximal convoluted tubule. Now SGLT, if we are talking about the SGLT, mainly they expressed into the proximal convoluted tubule. Now if we are talking about the proximal convoluted tubule, there is the majorly three segment, S1, S2 and S3, S1, S2 and S3. So majorly this SGLT2 expressed into the S1 and S2, S1 and S2, whereas SGLT1 it is expressed into the S3 or S2 S3 portion, that is the proximal straight tubule, proximal straight tubule. Now this SGLT2 it is responsible for 90% glucose reabsorption, 90%, more than 90% of the glucose reabsorption, whereas SGLT1 it is responsible for the less than 10% of the glucose reabsorption, less than 10% of the glucose reabsorption. Now we are going to discuss about the SGLT2 inhibitor. Now this SGLT2 inhibitor also called as a gliflozins. Now these gliflozins are considered as a newer class of oral hypoglycemic agent. Fluorescein, it was first isolated from the apple tree bark, and it was found into the different plant, and it was first isolated in 1950s, and then it was found that it is a non-specific inhibitor of SGLT1 and SGLT2, non-specific inhibitor, that is the fluorescein. So this is the structure of the fluorescein, this is the structure of the fluorescein. So fluorescein, as it is inhibitor of the SGLT1 and SGLT2, lowers the risk of the hyperglycemia and glucotoxicity. It is decreases the risk of hyperglycemia. However, this fluorescein, it is causing the non-selective inhibition of the SGLT1 and induces glucose galactose malabsorption, glucose galactose malabsorption as a side effect on the GIT. So major side effect is the glucose galactose malabsorption, and it has the poor bioavailability, clear, poor bioavailability. So subsequently it was not further used, and recently new drugs are there under the SGLT2 inhibitor. Now if we are talking about the SAR of this SGLT2 inhibitor, clear, SAR of SGLT2 inhibitor, what we can observe actually, what we can observe actually. Now here it is important that glycan and aglycan, this is the glycan part and this is the aglycan part, clear, glycan and aglycan link, clear, this glycan and aglycan link, this one. So this link is metabolically stable than O glycoside, it is metabolically stable than the O glycoside, linkage between the CC linkage between the glycan and aglycan part. Now R1, clear, R1, if we are talking about the R1, now here we can say that R1 substitution cause alter into the potency and selectivity. So in this, if there is a substitution, so there is a potency, alteration into the potency and selectivity. And generally recommended that small hallucinated methyl group, like CH2Cl, CH2Br, so small hallucinated methyl groups are recommended. Lipophilic substitution, clear, in case of the R1, lipophilic substitution is favored, clear, lipophilic substitution is favored. Next is R2, top activity. If we are talking about this R2, top activity observed with the strong electron withdrawing group like halogen, and weak electron group like ethoxy or CH3 ethoxy. So it was seen that this R2, if we are talking about the R2 halogen or ethoxy group, clear, halogen or the ethoxy group showing the top activity. And if we are talking about the R3, now if we are talking about the R3, electron donating group is favored. So electron donating group is favored, like we can say that like OCH3, then OH, these are responsible for the maximum activity in the R3, clear, in the R3 OH OCH3, it is called the maximum activity. So these are the some of the SGLT2 inhibitor and their structure. Gliflozin, this was approved into the USA, then European Union, Australia in 2013, and then in the rest of the world by 2017 it was marketed. Epagliflozin, it is approved into the USA and European Union into the 2014. Dapagliflozin, it was approved into the European Union in 2012 and US into the 2014. Recently in 2019 it was approved into the UAE for type 1 diabetes mellitus as a adjuvant therapy along with the insulin. Tofagliflozin, now tofagliflozin, it was approved into the Japan 2014, and epagliflozin, this one also in the Japan 2014. Now this drug sotagliflozin, this is the first drug which responsible for the inhibition of the SGLT1 and 2, clear, 1 and 2 inhibition, clear, 1 and 2 inhibition. So it is the dual inhibitor, and in 2019 again it was also approved into the European Union, this particular drug, for the treatment of the type 1 diabetes mellitus, management of the type 1 diabetes mellitus along with the insulin. Now coming to the mechanism of action, if we are talking about the mechanism of action of SGLT2 inhibitor, so it is important that action of the SGLT2 inhibitor is independent of beta cell function and insulin secretion. That means they do not have any effect on the beta cell function or the insulin secretion like that of the sulfonylurea, meglitinide, or we can say that metformin also. So they do not have any effect. SGLT2 inhibitor can be used into the type 2 diabetic patient. Majorly they are used for the type 2 diabetic patient provided the renal function is acceptable. Clear? Renal function is acceptable. Now as we have discussed that this SGLT2, it was present into the convoluted proximal convoluted tubule, that is the S1 and S2 segment, and it having the high affinity, low affinity, it having the low affinity but high ability of transport glucose, low affinity but high ability of transport glucose, and about 90% of glucose are transported or reabsorbed via SGLT2. Therefore, this is the main target of the SGLT2 inhibitors, major target of the SGLT2 inhibitors. And SGLT1, it is present into the proximal straight tubule, mainly into the S3, but also some S2 also, some cases you can find it. So, and it is responsible for the less than 10% of the glucose reabsorption. less than 10% of the glucose reabsorption. And of course, as we have told, some of the drugs are recently which is approved is used for the type 1 diabetes by inhibiting the SGLT1 and SGLT2, that is the sotagliflozin. Now if we see about the mechanism of action, this is the tubular lumen. These are the in the S1 or S2 of proximal convoluted tubule, and this is the S3 segment, that is the proximal straight tubule. Now if we see about this, this is the SGLT2 transporter, this is the glucose transporter which is SGLT2, and here we have shown that SGLT1, clear, SGLT1. Now here GLUT2 is present and sodium potassium pump also it is present here also. What will happen in the normal cases, glucose, majority of the glucose after absorption from the glomerulus filtration, majority of the glucose water, it will reabsorb back to the blood, clear, it will be reabsorbed back to the blood. Now glucose through this SGLT2, glucose and sodium, this through this transporter SGLT2 transporter, it will enter or reabsorb, clear, it will be reabsorbed. So glucose and sodium, it will be reabsorbed. After reabsorption, clear, after reabsorption, what we can find that they will use the GLUT, clear, they will use the GLUT and it will enter into the circulation. If you see that here, enter into the circulation, here it is entering into the circulation, via GLUT2, clear, it is entering into the circulation via GLUT2, and sodium and potassium pump, clear, through the sodium and potassium pump, sodium again it is entering into the circulation, and potassium it is coming inside the proximal tubular cell, clear, proximal tubular cell. So glucose through SGLT2, it will be reabsorbed from the tubular lumen, and then through GLUT2, through SGLT2, it is entering from the tubular lumen, that means it is the reabsorption of the glucose, and then using the GLUT2, it is entering into the circulation, clear, it is entering into the circulation. So here also the same mechanism, in the S3 segment also same mechanism is there. Now whenever we are giving the SGLT2 inhibitor, this is important, SGLT2 inhibitor, what they are doing, SGLT2 inhibitor cause the blocking of SGLT2, they will cause the inhibition of the SGLT2. Now if there is a inhibition of the SGLT2, so glucose cannot be reabsorbed, clear, glucose cannot be reabsorbed from the tubular lumen, and if the glucose is not reabsorbed, glucose is not able to go into the circulation, so ultimately in blood glucose level is reducing, clear, glucose level is reducing. How? SGLT2 inhibitors, they are inhibiting the SGLT2, so the reabsorption of the glucose it will be inhibited, and then through the GLUT2, so that glucose is not sufficient, so that it can enter into the blood through the GLUT2. So this is the mechanism of action of SGLT2 inhibitor. This is the mechanism of SGLT2 inhibitor. And as we already told that 90%, more than 90% of the glucose reabsorption takes place through SGLT2, clear, SGLT2. So by inhibiting this SGLT2, a large proportion of the glucose, it will be come out from our body through urine, clear, come out from the body through urine, and in the blood glucose level is reduced. Now sotagliflozin, as we have told, now sotagliflozin, it will not only block the SGLT2 but also block the SGLT1, clear, SGLT1. Now SGLT1 also, it is also, we have told that it is present into the intestine, clear, intestine. So there also this drug, it will going to act, clear, going to act. Now if we see that, already we have told that from the SGLT2, it is responsible for the more than 90% of the glucose reabsorption and less than 10% of the glucose reabsorbed through the SGLT1. Now glucose reabsorption, if we are talking about the glucose reabsorption daily, more than 179 gram, clear, glucose reabsorption more than 179 gram. And whenever we are giving the SGLT2 inhibitor, they will cause the SGLT2 inhibition and glucose reabsorption reduced to 100 to 130 gram per day. So it is reduced 100 to 130 gram per day because it is mainly acting on the SGLT2. Therefore majority of the glucose, it will not able to reabsorb and it will eliminate from the through urine, and as a result there is a blood glucose level, clear, blood glucose level, it will be reduced. So as we have told that urinary glucose excretion, if we are talking about the in the normally, because normally glucose is not excreted, it is less than the 0.5 gram per day, and by after the SGLT2 inhibition, urinary glucose excretion increases to 50 to 80 gram per day, 50 to 80 gram per day, and therefore it will cause the hypoglycemia, clear, hypoglycemia in type 2 diabetic patient. So this is the mechanism of SGLT2 inhibitor. Hope you have understood it, clear, hope you have understood it. Now coming to the uses, mainly this category of the drug used for the treatment of type 2 diabetes mellitus, clear, type 2 diabetes mellitus. This is a newer class of oral hypoglycemic agent. Significant improvement of the glycemic control, significant improvement of the glycemic control is observed. HbA1c reduced 0.5 to 1%. This is a significant amount, 0.5 to 1% reduction of the HbA1c it is observed. Dapagliflozin, this is recommended by the European Commission, approved by the European Commission for type 1 diabetes mellitus as a adjunct therapy, clear, as a adjunct therapy to insulin. That means it can be used along with the insulin. Whereas sotagliflozin, this drug, it is the type this is the drug which inhibit the SGLT1 and SGLT2. This was also approved by the European Commission for a oral therapy for a patient with body mass index, clear, with body mass index of 27 kg per meter square or more along with the insulin. So this is also along with the insulin, but BMI should be 27 kg per meter square or more. Though FDA, they have declined or they have refused the that is use of the sotagliflozin for the insulin, you can say that for the treatment of the type 1 diabetes, clear, type 1 diabetes. And SGLT2 inhibitor are generally contraindicated for the patient with the renal insufficiency, if the glomerulus filtration rate is less than 45 ml per minute per 1.6 0.73 meter square. So in that condition, it is the contraindicated. Other beneficial effect of this type of drug, that means SGLT2 inhibitors, include BP lowering effect. All these effect, whatever the effect we are going to discuss, it was found through the different clinical trials. In the different clinical trials, because it is a newer drug, so many clinical trials are going on. So it was seen that BP lowering effect, weight loss, pre and after load reduction, preload and after load reduction, improve renal outcome, prevention of the albuminuria, and slowing the renal function declining. So declining of the renal function also slow down by this type of the drug. Reducing the vascular disease risk factor, like it is enhancing the HDL, reducing the intestinal absorption of LDL, and increase the fecal excretion of the LDL. Reduces the albuminuria, already we have told. Reduce the risk of the cardiovascular death, mainly the dapagliflozin, empagliflozin. But as we have told that this is a newer class of the drug, and there is a different report that they might cause the risk of the different infection and the other condition. Like if we are talking about this type of the drug, increased risk of the genitourinary infection with the SGLT2 inhibitor, risk of the diabetic ketoacidosis. So FDA also warned about that risk of the too much acid in the blood and serious urinary tract infection. For that FDA also given the warning. And what FDA suggested? To stop the SGLT2 inhibitor and seek the medical attention if the patient having the any symptoms of the ketoacidosis. So if there is any symptoms of ketoacidosis, it should be stopped. Then FDA also found that like canagliflozin or the dapagliflozin, they may responsible for the acute kidney injury. Risk of the amplification, it was also found that canagliflozin, it may increase the risk of the leg and foot amplification. Hypotension, again the hypotension, it may be a problem, and increased risk of the bone fracture and decreased mineral density. This is also warning by the FDA. So all these have FDA also given the warning, increased risk of the bone fracture and decreased bone mineral density, that again with the canagliflozin. So these are the actually what happened whenever different drug are into the market, they are going into the clinical trial in the different brand name and all. So whenever they are giving the FDA and other things, they are giving the warning, they are giving it the brand name which contains this type of the drug. So this is all about the SGLT2 inhibitor. So this is the attribution and references. We have tried to discuss SGLT2 inhibitor in light of the current literatures, current research going on. And today's thought: education is the most powerful weapon which you can use to change the world, by Nelson Mandela. Thank you once again for supporting us. Thank you.